Good evening, everyone. Welcome to First Aid AMC MCQ session tonight. And this is your first class of free 2-week session, right? So many of you know about us, about First Aid, how we have been helping IMGs throughout the years to pass both AMC, MCQ, and clinical. So tonight's session is basically to give you an idea how AMC MCQ question works. And we are going to focus on some tips and tricks which you can use during your exam, which you can use during your preparation to find out how to come to the right answer. Because AMC MCQ exam is not a straightforward question. The questions will be full of traps. The examiner who makes this kind of question, they think that they know that what are the things that they can easily get into, and they usually understand that what will make a candidate to fall into that trap. So that's why we're going to show you today that how you can interpret an examiner thought and how you can easily find out the traps that they keep for you. And always there are some tricks, there are some clues in each of the question so that you can come to the right answer. So tonight class is not about a theory, not about showing you how to read John Murtagh or anything like that. We have a theory class coming up just I think in few days where we are going to discuss about cardiology, and that will be a theory class where you will learn the theory and basic. Tonight is not about showing that basic knowledge. This is going to be very difficult for you because you just started your preparation and many of you just enrolled into the course. So please don't get overwhelmed. This is not about showing that the exam is difficult. It's about understanding how the exam is going to work so that you can start preparation. So to start preparing for something, you need to know how the questions work. Otherwise, what are you going to prepare for, right? So you had a introduction class with me that was 1 month ago before Christmas, and we did discuss about the full thing about AMC MCQ. What are the questions that comes? What are the topics, subjects? We had a very good discussion, right? So today we are not going into that discussion anymore. If any of you did not do that class, I strongly recommend that you go and have a look in the YouTube and go through that class, because that is the first thing you need to know how exam works. What are the questions and topics and subjects that you need to prepare? So please make sure, if you haven't done it yet, make sure to go into our YouTube and have a go with that class. Now, just to give you a slight idea, AMC MCQ is a computer-based software exam. And the software is made in a way that it will give you questions based on the level of difficulty. Means that first question the software is going to give you is an easy question. And let's say you got it right. The next question is going to be a little bit difficult. And then the next question, if you got that question right, the next question will be a little bit more difficult. So the difficulty keeps on become more and more difficult until you got something wrong. Once you find out that once you get something wrong, okay, once you find something wrong, then the software will come back to the easy one. So this keeps on rotating like that. Each of you, if you, let's say that 5 friends think that they are going to sit together in the exam hall and they will just look at each other questions answer. Is it going to work? No, because each of your questions is going to be different. It's totally random. None of your questions in that same exam room is going to be same. So that's why please do not look at someone else's answer, because that person is getting completely different question. Okay? So the exam is about So you get to 150 questions, and out of 150 questions, each questions will carry different marks. 150 questions will have 500 marks. So you can understand that not each question carries equal mark in exam. Unfortunately, you don't know which question carries what kind of mark. So each question is equally important for you. And we know that last 30 questions are most important questions because those are not pilot questions. Those are definitely scored questions, and those carries high mark because everyone will run out of time at the end, and they like to do that, right? So they always keep the most important and high mark questions at the end of the exam. So now, recently, just last year, we found an email which was sent to many of our candidates that from this year, the exam questions are going to be slightly difficult. So what we found is that definitely a lot of students are passing AMC MCQ in comparison to AMC Clinical. So AMC has now introduced a little bit difficult marking system, which means that what we believe that the question will be a little bit difficult than the last few years. So our course is adapting to that kind of scenarios. So we are going to introduce a new thing for your batch is that we are going a little bit more deeper. Already the course that we provide, which is a span of 5 months, is quite extensive. We go through each and everything that exam can give you, but still AMC can make it difficult because there is no extent of how difficult a question can be, right? And there is infinite amount of questions that can appear in exam. So our plan is to make sure our candidates are well prepared for any kind of exam, whether it is easy or difficult, doesn't matter. We will make sure that you pass the exam without any problem. So in your batch, we are changing our notes a little bit more. We are trying to add more and more topics, even the topics that was not coming in exam before, we are going to include them so that if they want to make it difficult for you, you will be prepared. Okay, so the notes are going to be changed. We are going to update it mostly from John Mortag 9th edition, and we are taking a lot of things from therapeutic guidelines. And we'll take a little bit questions and topics from the eMedici, some of the QBank as well. So we'll see that if there is any kind of difficult scenarios come in exam, we'll make sure that you know those questions, you know those scenarios and topics by your heart. Okay. So that's the plan for now. Now, let's not talk anymore today. Today's session is not about discussing any of this. I just wanted to give you an idea so that you are well aware of the exam. So tonight is about solving MCQs, finding out the traps and some of the tricks and how the questions looks like in exam. Okay? Now, we keep you muted during the class just to make sure that we don't get any background noise. But please don't feel that this is not an interactive session. This is a completely interactive session. I always keep the chat box in front of me. So if you have any questions during the discussion, just write it in the chat box. You will always find that I'm answering your queries. Okay? So let's start. You can write your answer in the chat box and we'll go from there. Recalls or like the questions are covered in our class. Okay. All right. So this is your first question. Let me just remove this line someone has done. 。 So we've got a 17-year-old boy. So this is a very new topic that came in exam. So we have got a patient who is a 17-year-old boy presented with throbbing global headache and nausea, vomiting, no aura. So it's a throbbing global headache with nausea, vomiting, no aura. Currently on doxycycline for acne, history of intermittent headache and nausea. His vitals are stable. What is going to be your initial step? Now, it's important that you understand the type of question in the exam. The first and foremost thing to know is how to actually read a question. What are the important thing in a question? The most important thing in a question is what is the question itself. So the question is, what is the initial step? Now, in your exam, you will find out questions like this. So it could be, what is the initial step? It could be, what is the next most appropriate investigation or next most appropriate management? It could be, what is the next appropriate management or investigation? Or what is the next investigation? All of them are same. So initial, next most appropriate, next, or next appropriate, any of these are similar question. That means they just want to know what's going to be your initial step, or they have done something and what's going to be the next. Now, there is another type of question where the question will ask you, what is the most appropriate investigation or management? What is the best investigation or management? What is the definitive investigation or management? Now, these are not the next step. They're asking you to find out what is the best investigation for a patient who might have a pulmonary embolism or who might have myocardial infarction. So when they give you this kind of question, most appropriate, best, or definitive, it means they're not asking about the next, they're asking about the best one, right? Like, let's say that we have got a patient who has a cough and we are thinking of pneumonia. And the question asks you that what will be your initial investigation for a patient who has pneumonia? What do you think? What's the first thing you would do in a patient who might have pneumonia? Chest X-ray, right? That's your next step, or that's your initial step. But the same question, they're giving you a pneumonia case and asking you what is the most appropriate investigation, or what is the best investigation? What is the definitive investigation? What are you going to do for that? If you want to do a definitive investigation or most appropriate investigation in a pneumonia patient, what are you going to check? Especially bacterial pneumonia. Yes, sputum culture. If it is a patient with bacterial consolidation, sputum microscopy and culture is the most appropriate investigation because it's going to give us the culture, it's going to give us the organism which is the culprit causing the pneumonia, right? So now you get that understanding, right? That what's next and what is best. The same question can have different question. The same question can have a different way of answer. So same question can have different answer in this kind of way. So knowing the question, what they're actually wanting to know is the most important thing in AMC MCQ. Because if you don't know what they're asking, you're just going to choose the wrong answer. Clear? So once you know that, then you come back to the question again. So what I normally ask my candidates to do is read the question very quickly because you don't have a lot of time. So read the question very quickly and then find out what's the question asking for, and then again come back. Now, if I'm coming back to this question, I know this is a 17-year-old boy. What's the presentation? Throbbing headache with nausea, vomiting. I can see they gave a medication, which is doxy for acne. There is history of intermittent headache and nausea. So it means that it's not an acute headache. Like you're not thinking about a subarachnoid hemorrhage in a 17-year-old. You're not thinking about a stroke in a 17-year-old. So it's not acute. So something happening a little bit, let's say insidious or chronic for a couple of weeks maybe, but not an acute onset. Vitals is stable. Let's also make sure that it's not something really bad or something serious. And they're asking the initial stay. So when we read an MCQ question, the first thing we know that what is the presentation? It's a throbbing global headache in a patient who has nausea, vomiting, and it's a 17-year-old boy who is on doxy for acne. In your brain, you just do this. You just this doesn't need to happen like actively like how I am showing you now, but a candidate who passed the exam in his or her brain, this happens. So that's what you think in your brain that it's a 17-year-old having a global headache, nausea, vomiting. It's been intermittent. He's on doxycycline. What's my initial state? That's what happens in our brain when we are solving a MCQ, right? You can't just like read it. You have to do brainstorming. And that brainstorming will give you some ideas. You look at the option, you see that patient has, you have to stop doxycycline. EEG, which is electroencephalogram, that's for epilepsy, right? If we are thinking of epilepsy, then we will do it. CT head, MRI brain. Now, what's your thought about this case? What do you think? What's the diagnosis you will be looking for? So you guys are thinking about migraine, drug-induced intracranial hypertension, not bad. Drug-induced atypical migraine. Okay. The first thing about migraine headache is that it's not global. The migraine headache is usually unilateral headache. So it's a one-sided throbbing, pulsating headache. And yes, you can have associated nausea, vomiting. It's not necessary for a migraine to have aura. The common migraine will not have aura. Okay? It's not like that. So no aura, no migraine, that's not right. Most of the migraine will not have any aura. Okay? Now, this patient has intermittent headache and nausea. That might be a bit confusing for you. That's one of the things you might think that maybe this is migraine, but no. Migraine is not a global headache. It's always unilateral and it's throbbing. It is throbbing, pulsating, but it's not global. It's very unlikely. You guys are not wrong in a way that it is a condition that we call idiopathic intracranial hypertension, IIH. Or there is another name, which is the pseudotumor cerebri. So idiopathic intracranial hypertension, the symptoms are typically like this. So global headache, they get nausea, vomiting, and they don't get any focal neurological deficit, which means they will not come to you with diplopia or double vision. They will not come to you with hemiplegia, like one-sided weakness. They will not come to you with any other neurological deficit, no paresthesia, numbness, no aphasia, nothing like that. They will only come to you with a global headache, which is diffuse all over the head, associated with nausea, vomiting. But sometimes, if you do a fundoscopy, then you can see the papillary edema, which means that the optic disc so when you do the retinal exam with the fundoscope, the optic disc will get swollen, which is what we call papillary edema, which is very important finding for thinking of raised intracranial pressure. Okay, so you can get the papillary edema, but exam is not going to give you everything. So don't think that in a patient you will get everything positive for a particular case. And most of the time, exam will give you only few sign and symptom, not everything. So if you see here, idiopathic intracranial hypertension. Now, although it is less common in male, I believe that this was actually female in exam, but sometimes it can be a mistake. So it is less common in male, but it's more common in young, obese female. So it's very common in a female, let's say 25-year-old, obese, like BMI more than 30. Usually that is a common finding in this population. Now, idiopathic intracranial hypertension means that there is no cause of having raised intracranial pressure in this patient. That's why it's idiopathic. It just happens. Sometimes it can develop in the first time during pregnancy. So in a pregnant patient who is a bit obese, if they come to you with global headache like this and you get papillary edema, definitely you will think of IIH. Okay. So headache has the feature of raised intracranial pressure, typically worse when lying down, improved by upright posture. So again, exam doesn't give all the things. Sometimes what happens that when we see this kind of questions, it's completely different in exam. Exam questions sometimes carries more information, and you can get these findings. That will become a bit easier for you. So it get worse when lying down, but improved by upright posture. But it can get aggravated by coughing, bending forward, sometimes even a straining during passing bowel. These patients can have visual problems, so they can have visual field defect, and they can have a pulsatile tinnitus. So they can get this ringing noise in their ears. So it's not always, sometimes it can be there. Papillary edema is a very important feature of raised intracranial pressure. If a patient who has this kind of headache and has a papillary edema, that's an ophthalmic emergency, which means you need to send the patient urgently to the hospital or to an ophthalmologist, because sometimes they can lose their vision for this. Okay, so it is a medical emergency if vision is affected. When we find a patient with raised intracranial pressure, we also need to rule out some other possible causes. The most important thing to rule out is whether they have got a space-occupying lesion, like a brain tumor, any venous thrombosis, like the sinus thrombosis, malignant hypertension. Usually, the only way to rule this out is to do a MRI or MR venography. Some drugs such as doxycycline and isotretinoin can also raise intracranial pressure. So this is your exam question. And this is from ETJ, which is the therapeutic guideline. So you can understand that sometimes a tiny little bit of information can come in your exam. That's why from your batch, our main plan is to include a lot of therapeutic guidelines, because we see a lot of therapeutic guideline related questions in the exam nowadays. So we will focus side by side the 9th John Murtagh and therapeutic guideline together. That's the focus. And you will get a very extensive knowledge from both of them. Okay. If we suspect idiopathic intracranial hypertension, usually we have to send them to a neurologist. And to confirm the diagnosis, you have to do a lumbar puncture manometry, because in the lumbar puncture, you will be able to find out the pressure has got increased. If the lumbar puncture manometry shows the pressure is more than 25 centimeter, that will confirm the diagnosis. Okay, what is the treatment? Remember, first thing, if there is a medication which can cause raised intracranial pressure, we have to stop that, because That is the most common thing that should be rolled out first. Even after removing the drug, still patient having the same symptom, then you go for all the investigations and referral. If it is diagnosed that it is a patient who has idiopathic intracranial hypertension, in that patient, the most effective long-term treatment is weight loss. So if it is a overweight patient, we have to ask the patient to gradually lose the weight. Sometimes, if patient is struggling to lose weight, we can even offer them glucagon-like peptide, like semaglutide. You might be aware of Ozempic. So there's a lot of hype about Ozempic in Australia as a weight loss medication. So semaglutide is actually the ingredient of Ozempic. So this is a diabetic medication, but we can use it for weight loss. So that's the medication we can even try. In addition to weight loss, drug treatment to reduce the intracranial pressure without the visual symptom is going to be acetazolamide. Now, in combination with acetazolamide, we can also try topiramate. This too is our not like a main medication to treat this. Okay, so what did you learn? That's my thing. Did I just discuss with you that just this question? No. Do I ask you to just read the question and memorize the answer? No. The purpose of doing a question in our course is not to memorize the question, not to memorize the answer, nothing like that. It's to understand a topic. It's to understand what are important topics for an exam. Because exam question will be different. It's completely different. It's going to be a bit difficult. So we are going to prepare you topic wise. It's not a recall based class. It is a class where we are going to discuss recalls, but not to solve questions only, but to give you an idea about that particular topic and knowing each and everything about that topic. And that's what I want you to do. When you see a question that keeps on coming in exam, then it's not only just memorizing the answer of that particular topic. It's about knowing everything about that topic, knowing what are the symptoms, what are the physical examination finding for that, what are the causes, what is the treatment, what's the investigation, everything. So when you read a topic, you should read systematically. It's not just reading months and months of books, sites, and then you can't retain any information. That's something that you will do when you don't have any guideline or any guide or mentor to show you the right path. And I'm sure many of you have done that. Many of you have finished the whole John Mortar, but you can't remember anything. You can't get the answer right because it's not the way to read the topics. When you read a topic like this one, the first thing is what is the definition of idiopathic intracranial hypertension? What is the main symptom? We don't need to know the every symptom for this. What is the main symptom? Main symptom is headache, which is global, which has features of raised ICP. What is the main sign? Papilloedema. What is the investigation? We want to know what's the initial investigation and what's the confirmatory investigation. Then the management. What's the initial management and what's the definitive management? That's the only thing that you need to retain from a topic. Does it make sense, guys? I'm going to talk a lot today. I'm going to make sure that you understand the way of going through this MCQ exam. But remember, this is the most important class that you are going to have because you will learn a lot from here that what's really important and what's not important. Now, coming back to this question. So we know that this is a patient who has throbbing global headache. And remember one thing, if it was a migraine, they would not give a lot of investigations because migraine doesn't have investigations. It's a clinical diagnosis. Okay. Sometimes even looking at the options, you can get a good idea that what the examiner was thinking when he was writing this question. That's also one of the important thing. When you can't get the hang of the question, when you are not sure what the question actually means, sometimes looking at the option gives an idea. All right. So first of all, is there any other possible causes for this patient? 17-year-old tension headache is a possibility, which gives band-like headache, but it's not a throbbing headache. It doesn't come with nausea, vomiting. We know it is not migraine because migraine is not global. Can it be a case of cluster headache? Cluster headache is also unilateral, and they have these clusters of headache. Usually doesn't have nausea, vomiting, and they have unilateral watery eyes, unilateral runny nose. So none of the important ones are going in this case. So throbbing headache with nausea, vomiting, and we have doxycycline here, which is another clue. So we can assume that they're talking about raised intracranial pressure. It is very difficult to think of intracranial hypertension based on just this minimal information that we have seen here. I hope that in exam that you will get a little bit more information which will help you to think of raised intracranial pressure. In exam, it's not usually this vague. So once we think of raised intracranial hypertension or idiopathic intracranial hypertension, the first thing is any offending medication should be stopped before we consider anything. Okay, so that's your answer in here. There is no initial investigation for this. So the only way to investigate this patient is doing a lumbar puncture. Now, if you say that, can we do anything else before a lumbar puncture? Yes. And you should do it because sometimes if you do a lumbar puncture in a patient with raised intracranial pressure, what can happen? Guys, uncal herniation. So it can cause a herniation of the brain contents. So before we do a lumbar puncture, what should we do? Yes, so the initial step in this particular case, we should, yes, definitely do a CT scan or a MRI. Make sure the pressure is a bit stable. Make sure, yes, blood pressure should be controlled. But the main thing before you go for a lumbar puncture is making sure that you do a CT scan to make sure there is a low risk of having any herniation. Okay, so when it is safe, then only you go for lumbar puncture. And also you can even try reducing the pressure by giving the medication and then go for lumbar puncture if you really need to. But if you find in the CT scan of the brain that everything looks okay, there is less risk of having a uncal herniation, then you can go for a lumbar puncture. But definitely you're not going straight to the lumbar puncture without doing a CT. So your initial investigation can be a CT or MRI. All right, moving on to our next question, which is a very, very important question for your exam. Head injury in a rural area. So you've got a young boy, let's say it's a 20-year-old boy, brought to the rural hospital emergency department after trauma to the head. He was in a motor vehicle accident, unconsciousness with a GCS of 6 by 15. You have done the intubation, which is the first thing you will do. The neurosurgery unit is 3 hours from the rural hospital. What will you do next? So see that they're asking about the next step. So that's the first thing I have noticed. Then in my brain, I'm thinking what's the question is asking. So 20-year-old, I'm in the rural hospital, had a motor vehicle accident. This patient is unconscious with a GCS really bad, 6 by 15. I've done the intubation, so airway is protected. And what's my next step? I know that neurosurgery is 3 hours away. So that's what I'm thinking in my brain. I can see the option that transfer to the neurosurgery unit, do a CT scan of the brain, go for a straight bar hole, or go for craniectomy. What do you think you would do in this kind of situation? Okay, I can see most of you are going into the option two. Option two is a CT scan. Someone went for bar hole. So you're between these two. Not bad. You are right in a way. So this is a guideline which we took from the Surgeons Organization in Australia. And this is the head injury guideline that everyone follows, especially for rural and remote location. So this is the Australian guideline for or RACH, and this is a very, very important guideline. You should go through each and every page of this because a lot of questions come from here. Now, the main thing in here is we have got a patient with deteriorating head injury in a country hospital or rural hospital. How we know it is a deteriorating one? Any patients whose GCS is less than 9 by 15, they are definitely in a serious condition. Because less than 9, that means that they can't protect their airway by themselves. We have to intubate them straight away. So if you see a patient with any kind of injury, especially it happens after motor vehicle, if their GCS is less than 9 by 15, the first thing is to do the A, B, C, D, E. So airway, breathing, circulation. In your airway, the first thing is this patient's airway protected? Patient who is unconscious and GCS less than 9, they can't protect their airway. So first thing we will do is intubate. Okay? Then check the breathing. Is the patient breathing equally on both lungs? What's their saturation looks like? If the saturation less than 95, you start the patient with oxygen. Circulation, check their blood pressure. Is this patient is in any kind of shock? So is the blood pressure less than 90 over 60? If it is less than 90 over 60, start the patient with IV fluid if needed. So this is your first thing in a trauma patient, airway, breathing, circulation, right? Now, you have done this because already it mentioned you have done the intubation. There are questions I have seen where the question just delete this part. So they keep everything same, just don't keep the intubation. And in option 5, you got intubation. So there are questions like that. So if this patient was not intubated, we will need to do intubation as the first thing in this patient. All right. Now, coming back to our original question. So when we get this kind of deteriorating head injury patient, we look at what's our next step. Can we send this patient to the neurosurgery in tertiary hospital or not? Because this patient needs a neurosurgery team. But the question depends how long it will take for this patient to go to the nearest neurosurgery. Now, if it is less than 2 hours distance, then we can transfer the patient. So you'll transfer the patient to the neurosurgery unit in that case. While you arrange the transfer, which will be by air ambulance, not by road, you can reduce the raised intracranial pressure because head injury patient will have some raised intracranial pressure because they are bleeding inside or outside their brain. So what to do? Intubation we have done. We can give them mannitol. If their blood pressure is elevated, we will try to reduce the blood pressure gradually. Sometimes moderate hyperventilation can help with reduction of the raised ICP. Okay, so these are the things that we are going to do while we are waiting for the air ambulance to arrive. Now, what if it is more than 2 hours distance? We can't transfer them to neurosurgery because they will not live that long if you don't do something urgent. So you start your treatment in that rural hospital. So give them mannitol, moderate hyperventilation, head elevation, control the blood pressure, and sometimes you just go for barhole evacuation of clot, which is basically craniectomy or craniotomy. So the reason in this kind of case that this patient is already unstable because their GCS is bad. And if you wait for more than 2 hours for the evacuation of this clot or bleeding, most likely that the patient is going to be dead by that time. So you can't take that risk. That's why in the rural hospital, if CT scan is available, you do the CT scan and then go for barhole. So rural emergency will have a surgical team. They will be able to do the barhole. Okay. If not, to save the patient, any doctor might need to do that. Now, what if CT is not available? If CT is not available, then you look at the head injury part and you try to find out where the booginess is. Where is the swelling? The swelling part is most likely where patient is bleeding. And that's where you go for blind barhole in that case. Now, this is very unlikely it will ever happen in Australia because Australia usually well equipped for this kind of situation, but this is the guideline. Okay, so more than 2 hours distance. If CT is available, definitely we will do a CT. We will give all these medications and we will go for barhole. If less than 2 hours distance, if CT available, definitely CT. Then medication like mannitol, moderate hyperventilation, reduce blood pressure, elevate the head, and then you transfer the patient to the neurosurgery. Does it make sense? We can, because now we have intubated the patient. When the patient is intubated, then we can do a CT, and there is no other way. You have to do it. Otherwise, we can't find out the cause of the bleeding. So what are we going to do in this patient? This is a patient who is in the rural hospital, unconscious, 6 by 15 GCS, intubation done, so airway protected. But we can see the neurosurgery is more than 2 hours away. So we don't have the option of transferring the patient anymore. When something is in the option, means that it is available in that setting. So don't think that this is a rural hospital and CT is not available there. I worked in rural hospital and CT is there. So it is possible that CT will be there in a rural emergency. So in this particular case, definitely before going for barhole or craniectomy, we will go for a CT scan because the patient is intubated and intubation will keep the patient at least stable and the patient will need a CT because we need to find out what's causing this bleeding. Now, I'm going to show you this guideline just for an understanding of how to read from the links. So when you prepare for AMC, you need to learn how to search for questions, how to search the guidelines, because it's not like you will only read one book and everything will come from one book. It's not like that. So there will be multiple books, there will be multiple guidelines and website that we need to follow. And you need to know how to read those guidelines. Like this is a guideline of managing a head injury in a rural setting in Australia. There's a lot of things to know from here, and it is a good guideline even for surgery preparation because a lot of questions come from here just just because it is a topic related to surgery. So you can read that. I'm not going to go through all of this because it's not going to be helpful at the moment. So we can see that tracheal intubation is indicated if airway patency is inadequate or the GCS is less than 9, which you already know. When we get a patient, we do a primary survey. The primary survey is nothing but A, B, C, D, E. Airway, breathing, circulation, disability. Disability is just do a rapid neurological exam to check for their alertness, which is basically a short form of GCS. And then exposure. So expose the patient for adequate examination. So ABCDE is our primary survey. And then we resuscitate the patient. If airway is not patent, we intubate the patient. And the same way how I have mentioned, it's written all over here. You can read it in your own time. Then we do a secondary survey where we go through the whole body, head to toe, and try to find out any other injury this patient might have got. And then we do full examination, especially focusing on CNS exam. We make sure we find out the GCS of the patient. That's important. You should also know what are the absolute indication of doing a CT scan in a head injury patient. Not every patient who had a head injury will require CT scan. So definitely GCS less than 9 after resuscitation requires a CT. If a patient has neurological deterioration like hemiparesis, definitely CT is needed. Drowsiness or confusion, persistent headache, vomiting, focal neurological sign like hemiplegia, fracture, age over 50, or patient had a seizure after head injury. Any of these will require the patient to go for a CT scan. Our patients, mainly, this is the criteria. What is this CT scan? Anyone? So very common after head injury is epidural and subdural hematoma. In a CT scan, blood looks white. So if you see a convex line like this, so you see a convex line, that's extradural or epidural hematoma. And if you find out a crescentic shape, kind of a moon, right? If you see a crescent shape hematoma, that's subdural hematoma. And that's the most common cause of bleeding after head injury. Okay, many times this CT scan will be given in your exam, so you should know how they look like. And you can see these are some of the fractures in a skull after head injury. So after you have done the airway, breathing, circulation, resuscitated the patient, then you go for your definitive treatment. They have written what are the indication of a neurosurgical consultation. You can read that. What are the indication of transferring a patient to a neurosurgical service? You can read it. Now, management options for a deteriorating patient with suspected intracranial hemorrhage. That is the one that we are discussing here. So two course of action are possible. Transfer to a neurosurgeon within 2 hours, stabilizing the airway, which is your intubation, administering IV mannitol. If IV mannitol is not there, then alternative is hypertonic saline, which is 3% normal saline. If transfer is going to take more than 2 hours, barhole exploration on site by the country practitioner or a gen surge will be required. So this is from where I have taken my answer. So you can read a little bit more if you want, but that's the most important thing to know. Okay. Now you can ask me that which one come first, mannitol or CT scan? What do you think? Which one you would do in a real life scenario? Would you give mannitol in a patient, or you would take the patient to CT scan? What's going to be more important? Mannitol, right? Because this patient definitely having a possibility that this patient is definitely having a bleeding inside the brain. Otherwise, they will not have a GCS like that. So starting the patient with mannitol is much important than doing a CT scan. So first mannitol, then a CT. So first intubation, then mannitol, then CT. So once you stabilize the patient, then you can take the patient for a CT scan. Next question. So we've got a 23-year-old. Where can you find this link? So we will provide this link in the portal once you are in the course. So usually we upload all the files in the portal and you can get these links in the portal. Okay. So your student portal will have all the links. So the answer is B in this patient. So because we don't have mannitol in here as an option. So we have a CT scan. So we're going for the CT in here. We are not transferring the patient to neurosurg because the neurosurgery unit is more than 2 hours away. Okay. So moving on to the next question, a 23 years old motocross rider is brought to the emergency department following an accident. There is a 6 centimeter laceration over the anterior aspect of his tibia, which is clearly deformed. So that means that definitely there is a fracture in this patient. And when there is a laceration on the top of a fracture, what we call it? When there is a laceration or an injury on the top of a fracture, what's that fracture called? Open fracture, right? Good. See that this is when you are reading a question, you can also think it at the same time. So once you become a pro, you will be able to just read and think at the same time. Okay. So we've got a patient, motor vehicle accident with an open fracture. His foot is well perfused. That's the most important thing to know. If we find a patient with fracture, what do we first think? Neurovascular status. So is there any injury to the nerve? Is there any injury to the vessel? Right? So we can see the patient is having well perfusion in his foot, which means there is no vascular injury in this patient. We don't know about the neurological, they haven't mentioned, but that means they at least checked the neurovascular status. Which one of the following is the most appropriate initial step? So see that this is how the question comes. So you have to read the full question. Most appropriate initial means they're asking about our next step. So this is a patient with open fracture. There is a laceration and I can find out this neurovascular status is normal. What's our next step? So it's basically management of open fracture. IV antibiotics, fracture reduction, lavage, surgical debridement, or tetanus injection. In your exam, most of the time you will find out that two option is equally correct. Now, if you tell me that I know that this patient should have antibiotic, this patient needs to have a fracture reduction, this patient will need a lavage. So all of these, this patient will actually require. All of these are correct. So if I choose any of them, should I get like the answer right? No. Remember, it is the best answer. The exam is not about just the right answer. Exam is about the best option in that particular question. All right. So you will always need to think the best option in this particular case. That's going to be your answer in exam. So that's also one thing a lot of candidates just try to justify in their mind that I know that this patient should have an antibiotic. I know this patient should have a tetanus. So why, if I choose tetanus, it's coming as wrong? There is a reason. You justify in your mind that what comes first? What's the most important thing? I'll come to that. So we're going to discuss about the open fracture management from this guideline. So This is how an open fracture looks like. You can even see the bone sometime, right? So all patient after a major trauma, what's the first thing you will do? You will do the primary survey. Make sure their airway breathing circulation is good. That's the first thing you would do. And then once you make sure of that, in the secondary survey, you will find out that this patient has got an injury to one of the limb. Then once you find out, you look further. The limb should be assessed for signs of fracture and severity of the wound. Distal neurovascular function should be assessed. Gross contamination. So let's say if you see a lot of dirt, leaves, so mud on the top of the wound, you can remove them. So it's called gross contamination, which visually you can see, but you're not going to probe the wound without doing a proper anesthesia. So I've seen, like, remember, it's not a war. When a patient comes to you in the emergency department, I've seen patient, like doctors, especially junior doctors, they've seen a patient who is in a lot of pain, open fracture, and they poke and try to wash out the wound without giving a local anesthesia or without even putting the patient in any kind of painkiller. And patient screams. It's like a horrible thing to look at. So remember, you can't just poke a patient's wound without giving them proper analgesics or anesthesia. In Australia, it doesn't work like that. Gross contamination you can remove, that is not going to cause any pain. Anything that causes pain, you can't do it without a proper anesthesia. Okay? If you need to take the patient to the theater, put the patient under sleep, and then do a good removal of all the darts. That's what you're going to do. You're not going to put the patient in a pain. So gross contamination can be removed, but attempts at debridement should not be done. So you can't just do a debridement of the wound in an emergency department. You can take a primary photograph of the wound, and if a patient having, like, if the neurovascular status is compromised, so let's say you can't feel the pulse distal to the fracture, or patient can't feel the leg distal to the fracture, that means the neurovascular status is compromised. In a patient who has a fracture and their neurovascular status is compromised, they will definitely need a reduction of the fracture straight away. Okay, so you will realign the fracture at least. So you will reduce it and put a splint so that the limb or fracture component doesn't move. That you will do in the emergency. But that is only needed if the patient has a neurovascular status compromised. You don't need to do it otherwise. Tetanus and antibiotics should be given urgently. The earlier you give the antibiotic, the chances that this wound is not going to get a huge infection. For minor wound, you can give a simple cephalosporin like Keflex, or sometimes any kind of penicillin we can use like Flucox. That's usually for minor wound. For major wound, which looks really bad, we can even give gram-negative coverage with gentamicin or metronidazole. Once you have done this initial part, then you take the patient to the theater and then you do a proper wound lavage and debridement. And once you have done the debridement and lavage, then you actually manage the fracture by the orthopedics team. So the step-by-step approach in a patient with open fracture like this is, I'm just going to write in here so that you understand. So if we get a patient with open fracture, we first find out, is this patient's neurovascular status is normal, or is the patient neurovascular status is impaired? If it is impaired, the first thing we do is reduction. Now remember, the first thing, anything before doing anything is analgesics. So give them painkillers. So if painkiller is an option, definitely that is the first thing we will do in a patient with pain. Then we do the reduction and then we do the rest of the thing. If neurovascular status is normal, then we go for that patient, IV antibiotics will be the first thing. Then we look at whether this patient needs a tetanus. Does every patient needs a tetanus? What if this patient got a tetanus injection 1 year ago because he had a motor vehicle accident at that time as well? For a major wound, like this kind of major wound, if the patient had a tetanus injection in the last 5 years, we don't need to give them. If it was more than 5 years ago, then yes, we will give it. So, did the question mention anything about it? If the tetanus is your answer, they would at least mention about the tetanus. So what is the last tetanus in this patient? They would usually mention that, but they haven't. So that also should give you a hint in your mind that it looks a bit vague that if I'm choosing tetanus, why not they haven't given anything about tetanus in this patient? Even if the patient is unconscious, we can easily find out when was the patient's last immunization, because Australia has a universal Australian immunization register. We can go into the air and we can find out anyone's immunization status. So even if it's unconscious patient, we can find it out within a second. Okay. If it was more than 5 years ago, then yes, definitely tetanus will be needed in that patient. So IV antibiotic, tetanus, and then the patient will go to the operation theater for further treatment, which will be lavage, debridement, all of them. Okay. And in emergency, we can still realign the fracture segment if patient can tolerate it. If patient can't tolerate, it's too much painful, then we'll just do the initial management and take the patient to the OT for further management. Okay. So now both IV antibiotic and tetanus is equally right, because both usually in a real life situation you would give both together. There is no real answer in this. An exam loves to do this kind of thing because they know you will be confused. But think, in a patient who has an open fracture, what is the most common thing to happen? Infection. So an infection in this kind of wound is really, really bad. Is tetanus is very common in Australia or anywhere? No. But still, we want to make sure patient doesn't get a tetanus. That's understandable. But between antibiotic and tetanus, antibiotic is the most important ones. Okay. So if we want to choose antibiotic or tetanus, because both are equally right, but we have to choose the right answer and the best answer, we're going to choose the antibiotic in here. Okay. Same patient, I've seen another question where they said that the pulse is absent in this patient. So if pulse is absent, what will be your answer in that case? In that case, you will choose the fracture reduction. So it's important to read the question fully. I've seen a lot of candidates have this idea in their head that if you do 1 year, 2 year recalls and you just do a Q bank, you can pass the exam. Can you? No. It's a myth. It's something some people, and I've seen a lot of scammers nowadays, which is running everywhere. And please be very careful before buying anything from these people, because there is people, I think like about 20,000 Australian dollar a person has taken from multiple candidates, saying that he or she is going to give some course materials and all, and ended up being a full scammer. So please do not get involved with these kind of things. People who wants to spoil candidates like you, they will say a lot of things, but in this kind of era where technology is like this, it's important to be very careful. So please do not just just contact with this kind of people who is offering materials, giving, asking you for your bank details, asking you for your whole details and all. Please do not go for that. Now, coming back to our things. So we were saying that when we are discussing something or when we are talking about something, it's important to go through the full question, because the same, you might think that it's the same question that you have read or you have seen somewhere, but it is absolutely different in exam. And you think that, well, I knew that Dr. Arshan said that this question's answer is IV antibiotic. So I'm just not going to even read the question. I'm just going to follow him because I follow him 100%. Now, is it my fault that you are doing this blindly? No, I'm not going to take that fault, because it's your fault that you are not reading the question even. It's your fault that you are memorizing a question which is not what we are showing you. So what's I'm showing you? I'm showing you the management of your open fracture. Learn it. Read the guideline. And that's how you can become a good doctor. A good doctor is not going to just memorize things and think that if I memorize 1 year recall, I'm going to pass the exam. This is not how it should be. It's not about ethics. It's about being a good doctor, because you're not just going to pass this exam. You're going to be a doctor in one of the most, like, we know that Australian health system is the second best health system in the whole world. So you're going to be a doctor in this kind of sector where principle, knowledge, experience, everything matters. Being a doctor only, like just being a doctor here doesn't actually matter anything. If you're not a good doctor, knowledgeable doctor, you're going to end up getting sued by that patient. You're going to kill a patient here because you just thought like just memorizing a question answer is going to make me a doctor in Australia. It's not like that. Please make sure that this is the time that you can grow, you can get that basic knowledge that will help you to be a good doctor whose knowledge is in that level that the the Australian people will come to you because they think that your knowledge is much better than a doctor who passed from Australian health system. So you prepare yourself as a doctor like that. Okay, so that is important, and you have got the time now. So if you bypass the first thing that's going to be your basic or the pillar of your journey to be a doctor, you're just bypassing everything in your life that you have worked for. All right. So it's not about recalls. I always say we do solve questions, but it's not about that. We solve questions to make sure you understand the topic, make sure you know the topics that is important. Okay. So that's what you need to think in your head. Okay. So when we get a patient with open fracture, we look at their neurovascular status. Neurovascular status means how is their pulse, and is there any loss of sensation distal to the fracture. If any neurovascular status is compromised, then you go for reduction straight away. If neurovascular status is normal, then you will choose IV antibiotic, tetanus if needed, and take the patient to the OT. But any management, the first management is always analgesics. If that is in the option, that should come first. So painkiller is always the first thing that we will do. So what do you mean? Tetanus is not mentioned in the scenario. Why not we go for tetanus? What do you mean? As I was saying that both tetanus and antibiotic is a possible option, but you can only choose one answer. You can't choose multiple. You have only one best answer to choose. Between antibiotic and tetanus, that's the most appropriate one, because First, this kind of open fracture can become really bad infection. The infection can spread everywhere, causes sepsis, patient can die. And you can just prevent it by doing this. Tetanus is important, but it's not very common. But still, this is our second option to choose. Okay. Yes, IV antibiotic is the right answer in here. Always. If you need to choose between antibiotic and tetanus, especially for a open wound like this, antibiotic will come first. Okay. Now, an interesting question. A 45-year-old female comes to the clinic with a progressively enlarging firm painless mass in her neck. Had a low-grade fever, fatigue, weight loss over the last few months. On exam, you noted a hard, fixed thyroid mass that is adherent to the surrounding structure. No history of dysphagia, hoarseness, or thyroid dysfunction. Blood tests show normal thyroid function, slightly elevated ESR-CRP. Biopsy shows fibrosis and lymphocytic infiltration. What is the most likely diagnosis? Okay, this is how exam questions looks like. Questions are usually complete like this. So we've got Hashimoto's thyroiditis, Riddle's thyroiditis, papillary thyroid cancer, subacute thyroiditis, and Graves' disease. It's a difficult thing for most of you. I do understand it. So many times these questions just comes once in a lifetime, but sometimes it keeps on coming. So you have to have a good idea about all of this to come to the right answer. So let's come into a bit of a discussion. So this is a case of Riddle thyroiditis. It's a rare condition which causes fibrosing inflammatory disease of the thyroid. So if you see here, biopsy shows fibrosis. Okay. And it's an inflammatory condition. That's why there is a bit of elevated inflammatory marker. So everything is there. You just need to know it. If you know it, you can usually click. So it's an inflammatory fibrosing condition of the thyroid. Often it looks like a cancer, but biopsy confirms that it is not a cancer. So it's a hard fixed mass which is adherent to the adjacent tissue. We have got exactly the same thing, right? Hard fixed mass adherent to the surrounding structure. So that's what we find in a Riddle thyroiditis. Biopsy will show dense fibrosis, inflammatory infiltration, often with lymphocyte, but mainly eosinophilic infiltration. So you can get both lymphocyte and eosinophil in this patient, but we can see the biopsy found lymphocytic infiltration, which is fine. It can happen, it can have both either lymphocyte or eosinophilic infiltration. Thyroid function is usually normal, ESR-CRP usually elevated. Treatment in this case is a steroid because it's an inflammatory condition. Now, how we know it's not others? So first of all, one of our option is papillary thyroid cancer. Papillary thyroid cancer, if we do a biopsy, it gives us this specific finding, which is called orphan Annie eye nuclei. So if you see the orphan Annie, so see this thing over here. So it looks like an eye, and that's what we call orphan Annie eye, which is nothing but it's an empty nuclei with a central clearing. If you look at it, you can see it's pale in the center. So all of these are called orphan Annie eye nuclei. That's the most important things. We can also get these Samoma bodies. These two you should remember because biopsy, if it is a papillary cancer, it will definitely say that either it has the orphan Annie nuclei or it has the Samoma bodies. But our patient's biopsy doesn't have any of them, right? How about the next common one? So papillary thyroid cancer is the most common thyroid cancer. Next is follicular thyroid cancer. Follicle, as the name implies, the biopsy will show a lot of follicles. Usually, just by doing a FNAC, you can't be sure whether it is a cancer or not. Most of the time, what happens is that the biopsy will come as inconclusive. There will be only follicles in there. But if you are concerned, you need to remove the full thyroid gland and then send it for histopathology. Then it can confirm. Medullary thyroid cancer. Medullary thyroid cancer gives this kind of amyloid stroma. And sometimes you will find out that they talk about nest of polyclonal cell. You can get Congo red staining showing an apple green bifurcations. So these things you just need to memorize, nothing else. I can't help you with this, but you can only remember them. So if you get a biopsy report showing amyloid stroma, polygonal cell, then you can think of medullary thyroid cancer. And then the worst one, anaplastic thyroid cancer, we get highly pleomorphic giant and spindle cell. We get a lot of mitotic activity. So it's quite aggressive. So it's very uncommon, but if the question says or the biopsy shows multiple different shapes of giant cell and spindle cell, then we can think of anaplastic thyroid cancer. So this is a very good discussion about just to know the main thing. It's very difficult to go through everything. And in a recall class or a question solve class, we don't go through the full topic. There is a reason for it because the theory classes are meant to discuss these things in detail. So understand the difference between a theory class and a question solve class. Question solve class, we are just going to focus on a particular topic and just the important thing we will discuss. But when we have a theory class, the same thing we will go very deep, very detailed. Okay. So how to come to the diagnosis now? So we know it is not a papillary cancer because this patient haven't got any orphan, any nuclei in the biopsy. Why not it's Hashimoto's? Hashimoto's thyroiditis is the commonest cause of hypothyroidism, but this patient's thyroid function is normal. Most importantly, Hashimoto's thyroiditis, it gives a painless goiter. So you can get a painless goiter, but not painful. They will not have fever. They will not have weight loss. Okay. And definitely it will not be hard and fixed. It is Riddle's thyroiditis. Why not subacute? Subacute is the most common cause of painful thyroid gland. So this is the commonest painful thyroid gland cause. Now, usually subacute thyroiditis will have a recent viral infection. So question usually will give you the clue that patient had a recent flu-like illness and then patient having a painful thyroid gland. That's subacute. But this patient's showing painless mass. So it's unlikely to be subacute. Graves' disease, the most common cause of hyperthyroidism. And Graves' disease doesn't come as low-grade fever. Usually Graves' disease will have ophthalmic manifestation. That means they will involve the eye. Without eye manifestation, we usually don't think of Graves. And we'll discuss that in our class, but you get exophthalmos, so the eyeball usually protrude outside. You get lid lag, lid retraction, all of them. So this patient doesn't have that. So even if you can't, even if you don't have any idea about Riddle thyroiditis, just by exclusion method, you can come to the right answer. So that is another way to come to the right answer in exam is called exclusion method. So you know the others, like most of you know about this, especially you will know about it if you have a good preparation. We don't discuss Riddle thyroiditis because it's very uncommon. But let's say it came in your exam. You know all the other option. Then you can just exclude them by your logic, by your knowledge. Then you can even come to the right answer. Okay. In cancer, ESR CRP can be raised, yes, but that's not the only thing that we'll think of cancer. You did a biopsy, and biopsy should be confirmatory to say it is a cancer or not. Okay. No, you can't exclude carcinoma by inflammatory marker. You can exclude cancer by doing the biopsy. Okay. Focal seizure is not commonest manifestation of Graves' disease. Okay, moving on to the next topic, we have got a diabetic patient with ulcer on his right foot. There is two deep ulcer at the medial malleolus and foot with skin necrosis and inflammation. The HbA1c is 6.5%, which is good. HbA1c less than 7.5% means the diabetes is well controlled. So this patient's diabetes is well controlled, but still it's a diabetic patient with the ulcer. It's always concerning. He was admitted and antibiotic was given. You have taken swab, send it for microscopic culture. What will you do after that? So what we have got is a diabetic patient with an ulcer in his foot. Now, usually exam question will give you a little bit more idea. They will say that this is an ulcer which is non-healing ulcer. So most of the time it comes as a non-healing ulcer, which means an ulcer which did not heal in 2 weeks. Okay. Now, in a non-healing ulcer, plus it's a diabetic patient, what's the most concerning thing for that particular patient? Especially we understand from the question that this patient was given antibiotic. That means the ulcer is also infected ulcer. So that gives you a bit of a clue what we should think of. Yes, in a patient who has a non-healing ulcer and it's a diabetic patient, and if it is infected, our main concern will be osteomyelitis, which is the infection of the bone marrow, right? So that is our main concern in a patient who has a diabetic foot infection. Now, let's have a look. So we are now going to discuss about the diabetic foot infection. It's commonly asked in exam, very complicated if you don't know the step-by-step approach. So this is how we can see diabetic foot infection can get better gradually. So there are stages of diabetic foot infection. We divide it into mild, moderate, and severe. It's important because it helps us to manage this patient. So let's say mild is local infection only involving the skin and subcutaneous tissue, and there is no sign of inflammatory response. That means there is no fever, there is no nausea, vomiting, there is no sign of systemic infection. Okay, so it's just a localized infection, and the around the wound, the redness is less than 2 centimeter. So let's see, this is then wound, and you can see there is a surrounding erythema. If this surrounding erythema less than 2 centimeter and the patient doesn't have any systemic symptom, that means we can call it mild infection. What is moderate? It is still local infection, but the surrounding erythema is more than 2 centimeter, or it has involved the deeper part of the site. So patient having abscess, fasciitis, osteomyelitis, but it's still no sign of systemic infection. That means it's still no fever. That's moderate. But when the patient has moderate but having a feature of systemic infection like fever, then it becomes severe. Okay, so now we know what is mild, moderate, and severe, because based on that, our antibiotic will be different. So choice of antibiotic for mild infection, we can try oral antibiotic. Can be any of these. So commonest could be cefalexin. So first generation cephalosporin. You can try flucloxacillin, amoxiclav, clindamycin. Any of them is fine. Most commonly, we will give either Keflex or Fluclox. In case of moderate infection, patient usually will be admitted for IV. So we give IV augmentin or we give IV cefazolin plus metronidazole. Usually, IV augmentin will be the first choice. In case of severe infection, we try to cover the gram-negative ones. So we give Piptaz, which is piperacillin and tazobactam, which is the commonest one we will give. Or we have other options like sulbactam, clavulanic acid, or ciprofloxacin. All right. So this is your choice of antibiotic. It comes in exam, so you should know. So we know about how to treat the infection in a diabetic patient, right? So let's say we have got a patient with diabetic foot infection. Okay. And we can see there is a bit of a yellowish discharge coming from the wound. That means it is infected. What's the next thing? We take a swab from the wound, just like the question. So sometimes even reading the question gives you an idea what is the next step. So taking the swab, after we take the swab, then we start antibiotic, right? So first we took the swab, and if it is a bit infected, we do a bit of a wound toileting, which means cleaning the wound with normal saline, and then we start the patient with antibiotic. That's the step-by-step approach. Now, it's a diabetic foot, but it's a non-healing ulcer for 2 weeks. Any diabetic foot infection, if it is non-healing and infection looks bad, you will be very concerned about your osteomyelitis, especially if the infection looks a bit deeper. If you are concerned about possible osteomyelitis in a diabetic non-healing ulcer, your next investigation should be X-ray, but many times osteomyelitis will be missed in the X-ray, especially if you do it early in the first couple of weeks. Most appropriate to diagnose osteomyelitis is MRI or bone scan. Okay, so that's what exam question will give you. Now, I took this from Diagnostic Imaging Pathway Australia. This is the step-by-step approach of managing a diabetic foot ulcer, especially when you are concerned about osteomyelitis. When are we concerned about osteomyelitis? It will be extremely painful. You will not be able to touch that wound. There will be sign of infection. That's the time you will be thinking of osteomyelitis. So you thought about osteomyelitis, you did an X-ray. An X-ray shows there are features of osteomyelitis like bony erosion. If it shows that, that means this patient has osteomyelitis. You don't need to do anything. Treat the patient for osteomyelitis with IV antibiotic. But X-ray missed it. X-ray saying that, no, we can't find out anything. But you're still concerned. Then you do this. So can you see the bone from the ulcer? So when you are examining the ulcer, can you see the bone? If you see the bone on view, that's a definitive problem because the ulcer should not go that deep that you could see the bone. Let's say you can't see the bone, then we use a probe. Now, if you insert the probe and you can reach the bone, that's also suggestive of a osteomyelitis. So this is what we call bony probe. You must have seen that. So if we insert this probe and probe touch the bone, that's also concerning for osteomyelitis. So if that is the case, you presume that this is most likely osteomyelitis, then yes, I would not just start the patient with treatment. You would still do a MRI or bone scan to confirm. Okay. Let's say bone is not on view, you can't probe to the bone, but still you are clinically highly suspicious of osteomyelitis. In that case, still consider doing a MRI. If MRI is not available, you can do a nuclear medicine scan, which is a bone scan. Okay, does it make sense, guys? So if we now come back to our question, so they took swab, they started antibiotics, so they have already started the treatment of infection, but this is a non-healing ulcer for 2 weeks. If you look at this option, you know that they are thinking of osteomyelitis. You have got option of X-ray, MRI, bone scan, right? Why Doppler will be important? For a diabetic patient, Doppler is important to rule out any associated peripheral vascular disease. Complete blood count is not going to give us anything in here. So what will you do after that? That means next step. Are we going to do an X-ray, MRI, or bone scan? That's the question. How will we detect erythema in a dark skinned man? It's not about always erythema, there will be some changes. So even if it is a dark skinned man, you will see some changes around the wound. There will be some discoloration, that will be enough to know. Yes, so this patient will require an X-ray first. If X-ray shows osteomyelitis, that is enough. If it doesn't show, then we will consider doing an MRI. If question asking here, what will be your most appropriate investigation, or what's your best investigation? That's the time we will choose MRI. Okay, so depends on what question asked. Now, out of anything we discussed, this is the most easiest question today. A young man working came to the ED with big abscess. When to choose bone scan if MRI is not available then? A young man working came to the ED with big abscess under the arm. After draining the abscess, what is the investigation of choice? Antibiotic, full blood count, own culture, ultrasound, or CT of the arm? Definitely. So if you do the draining of the abscess, the first thing you will do is to take a swab, send the swab for culture, and then start the patient with antibiotic. Okay, good. Next, a 32-year-old lady came to the clinic with complaint of tingling sensation in bilateral lower limb. So bilateral lower limb tingling sensation. Has a history of peripheral arterial disease, hypertension, hyperlipidemia, taking indapamide. Indapamide is a diuretic for hypertension, atorvastatin, which is a statin, and perindopril, which is ACE inhibitor for hypertension as well. Loss of sensation below the ankle and decreased reflex bilaterally below the ankle. That means ankle reflex is absent or decreased. Most likely cause. So what do you think the diagnosis is? Bilateral tingling sensation with loss of sensation in the lower leg. What is called? What it is? It's called peripheral neuropathy. Yes, very good, Dr. Dipsika Selina. So peripheral neuropathy means the the nerves in the extremities is impaired and the nerves are not sending signals to the brain. What is the number one, or if I ask you the most two common causes of bilateral peripheral neuropathy, what would you say? Yes, you guys are good. So B12 deficiency and diabetes. That's the number, that's the two most common cause of peripheral neuropathy. Okay, there are lots of other causes, but that's the most two important things that we want to rule out. Now, we have got options of diabetic neuropathy, lumbar disc herniation, which can cause sciatica, B12 deficiency, and drug side effect. Okay, so their question is, what is the most likely cause of the symptoms this patient having? Now, if I want to know how you're going to come to the diagnosis, tell me, tell me what you think. Think of the answer. Is it diabetes? Is it B12? Is it lumbar disc? Is it drug side effect? Okay, I can see you guys have chosen all the options. Okay, let's talk about it. So, peripheral neuropathy is an important topic for exam because the simple things sometimes can be quite difficult and confusing. So when we get a patient with peripheral neuropathy, so how we know it's a peripheral neuropathy? The most common symptom is tingling numbness sensation in the extremities. And it has this glove and stalking loss of sensation. Okay? So usually common in both fingers and the toes. So they complain they get these pins and needles, numbness, tingling in their foot, in their feet or in their fingers. When you examine them, you will find out there is a definitive point of loss of sensation. So you'll be able to find out the exact location of loss of sensation. Like let's say this patient, let's, sorry for my drawing. So let's say that's the leg. So you'll find out that they have a definitive point of loss of sensation. That means all of this, they can't feel anything. Okay? Because they can't feel anything, that's why usually ankle reflex will be absent. Because for a reflex, you need to feel the touch as well. So if we look over here, this is our nervous system different kind of tract. Now, I'm not going to the neurology in detail. In our neurology class, I will discuss all this descending, ascending tract. But just to get a good idea that the ascending tracts are our sensory fibers, which carry all the sensation from the periphery into the brain. We have got dorsal column, we have got a spinothalamic tract. Spinothalamic controls our pain and temperature sensation, whereas dorsal column controls our touch, proprioception, and vibration. What happens in patient with B12 deficiency, they get a condition called subacute combined degeneration of a spinal cord. So subacute combined degeneration of a spinal cord means they have got combined degeneration. It causes degeneration of dorsal column. It causes degeneration of the corticospinal tract. So the corticospinal tract is the descending tract, which is a motor tract, which means that you get a sensation. Let's say you got a, if this is your hand, okay? Let's say this is your hand and a mosquito is just over here. Your ascending tract, which is like the touch, or if you are getting pain from the mosquito bite, so any of this tract will get activated and it will go to the brain and brain will get the sensation that yes, something is there. Then the motor tract will be involved, and the corticospinal tract will involve, and with your other hand you will kill the mosquito, right? That's how it works. Now, in a patient with combined degeneration of the spinal cord, their dorsal column, that means their vibration, proprioception, that sensation will be impaired, and then also their corticospinal tract, that means the motor function can get impaired. But it's the sensation which will be impaired first, and that will be more evident. So in this patient with subacute combined degeneration, we will find out they have impaired proprioception, which is the balance, then vibration. They will come to you with paresthesia, which comes in the form of tingling, burning, loss of sensation. Lateral corticospinal tract dysfunction will, so gradually patient will have muscle weakness, the reflex will be increased, rest of the body reflex will be increased, but ankle reflex usually absent. Okay, so that's what we have found in this patient. Everything is there. So we have got a patient with tingling sensation in the lower limb. They have got loss of sensation below the ankle and decreased reflex below the knee, which is basically the ankle reflex. Okay, this patient is already getting some of the feature of subacute combined degeneration. All right, now can it be diabetes? It can, but this patient doesn't have diabetes. So far from this, we can't see that this patient is a known diabetic. So we don't think of diabetic neuropathy without anything in the history suggesting diabetes. So we can rule that out. Then drug side effect. Any of the drug can cause this peripheral neuropathy. If you say that, yes, statin sometimes can cause this, but the guideline is still, the evidence is not strong that statin causes B12 deficiency or statin causes peripheral neuropathy. The most common side effect of statin is muscle weakness, myalgia, but not this. Okay, yeah, it's more towards myopathy rather than causing neuropathy. Lumbar disc herniation. What's the most important symptom in a patient who has a disc herniation? If you have a disc herniation, you will know the number one complaint, pain. They will come to you with back pain first. They will not come to you with loss of sensation, right? So this patient doesn't have a back pain. So even without a back pain, thinking of sciatica is really, really less likely. Okay. So this patient has B12 deficiency causing all this peripheral neuropathy symptom. Okay. Make sense? So there are lots of causes of B12 deficiency. Most common cause is if they're a vegetarian or if they're not taking a like good amount of red meat. Then the other thing could be that if they're having any malabsorption, sometimes we can't just find out the cause. One of the other cause is pernicious anemia that also come as B12 deficiency. Someone who has a gastrectomy or a bariatric surgery, they can have B12 deficiency because you know that for B12 absorption, you need intrinsic factor, which is produced in the stomach. So someone who is having gastrectomy, bariatric surgery, they will not have enough parietal cell to produce intrinsic factor. That can be the case. If someone has iliac like malabsorption, then we know that B12 get absorbed in the terminal ileum. For malabsorption patient, it cannot be absorbed. So there are a lot of causes of B12 deficiency, which is another thing to find out. The first thing is what is the cause? So B12 deficiency. Then we find out what's the cause of B12. Okay. Yeah, sometimes even proton pump inhibitor can cause that. Which one, Shushmeta? Which one to repeat? Okay, so that means it's a full discussion we are doing for peripheral neuropathy, Shushmita. So it's a case of peripheral neuropathy, and we know that the most common two causes are this. And in a patient, always think in the exam the common things. Common things are the first thing. So B12 deficiency is the cause of peripheral neuropathy, and your patient is coming to us with tingling sensation in the lower leg. Your patient is having loss of sensation below the ankle. So it means that this patient has peripheral neuropathy. And we need to find out what's causing this because that's our question. We know the cause of peripheral neuropathy is B12 deficiency or diabetes. That's the commonest cause. And we have got both option in here. Okay. Now, then we did the exclusion. Does this patient has diabetes or any feature of diabetes? Any medication that they are talking? Nothing. Nothing related to diabetes here that we can think it could be a diabetic neuropathy. Okay. Can it be B12 deficiency? Yes. The reason why we're thinking B12 is that it's more common than diabetic. The second thing is that this patient has feature of subacute combined degeneration. Not the full part, but this patient has got decreased reflex below the ankle, which is basically a feature of subacute combined degeneration. Loss of sensation below the ankle, which is there, which can be there even in a diabetic patient, but the both reflex low is not usually a feature of diabetic neuropathy. Okay. We can't just assume the patient is diabetic because the patient has peripheral artery disease and hypertension. We can't assume that. And most importantly, the patient has reflex changes. Diabetic neuropathy usually doesn't present as like having bilateral ankle reflex absent. It's uncommon. All right. I believe this is going to be our last question for tonight. So, but this is a very important one to know. Okay. So, we're discussing about post-operative fluid management. So, a previously fit 55-year-old man had an emergency right hemicolectomy because the patient had a perforated cecal cancer. 2 days after the operation, this is post-operative day 2, you had this following fluid balance sheet. So this patient has got input of 2 liter. So 2 liter IV fluid was given, and then output. So nasogastric aspiration 2 liter, drain loss 700 ml, urine output 500 ml. Now, apart from these losses, everyone usually have some insensible loss. So loss from their skin, from sweating. So even sometimes even the skin cell. So we can't actually measure them. So we keep a constant value, which is 500 mil for those insensible losses. So if we add all of this, what it comes? So 2 liter, 700 mil, 500 mil, and 500 mil. So we've got 1 liter, 2 liter. So we've got 3 liter. So 3.7 liter, right? Now For the purpose of math, make it simple and make it whole. So make it 4 liter. Okay? Is this making sense so far? Everyone? So now you know how to calculate the input and output. So input is 2 liter and output, we already know this patient has 2 liter NG tube aspiration, drain loss 700 mil, urine output 500 mil, and insensible loss 500 mil. Together it is 3.7 liter. We just made it whole as 4 liter. Okay. So this patient's input is 2 liter, but output is 4 liter. That means he's having a deficit of 2 liter already, right? Now, how we are going to do a maintenance fluid in a post-op day 2 patient? So in a post-operative patient, every patient, doesn't matter the deficit, every patient, especially because this patient will not be able to eat. Someone who can eat, we don't do this kind of calculation. This patient had a hemicolectomy. He will be on a fluid management because he will not be able to eat in 2 days, right? So for someone like this, the maintenance fluid will be 1 liter normal saline, and we have got 2 liter dextrose. So that's our normal maintenance dose plus 20 milli equivalent of potassium per liter of fluid that we are going to give, because they will lose potassium through all the drains and all. So this is for everyone. So 1 liter normal saline, 2 liter dextrose plus 20 milli equivalent potassium per liter. Every liter of fluid we are giving, we will add 20 milli equivalent potassium. Now, this is for maintenance. That's for everyone. Then you need to also add if there is any deficit. We know this patient has a deficit of 2 liter. So you need to add that 2 liter in that normal saline. We don't give it too much dextrose to the patient. So we don't want to give a lot of dextrose. 2 liter is enough. So we add that deficit in the normal saline. So you add the 2 liter normal saline. So what it comes? 3 liter, right? So now it's 3 liter normal saline, 2 liter dextrose. So how much fluid we are giving in 24 hours in this patient, guys? 5 liter, right? So if we give 5 liter fluid in this patient, how much potassium this patient will require? So we know every liter will get 20 milli equivalent potassium. So 5 liter will get 5 into 20 means 100 equivalent potassium. So 100 milli equivalent potassium for this patient. So that's your answer in here. 3 liter normal saline, 2 liter dextrose, 100 milli equivalent potassium. Okay. From post-op day 2 is fine. Definitely not post-op, not post-op day 1. That's right, Dr. Munir. So if it was a post-op day 1, we would not add it. Post-op day 2, so you can see it's actually post-op day 3, 2 days after the operation, right? So it's actually the post-op day 3 in this patient. So post-op day 2, still we try to avoid the potassium. And yes, from the day 3, we will start it. Patient doesn't need to get 2 liter. Usually they would get 1 liter, but they got 2 liter anyway, just to make sure maybe they have lost a little bit more on the day 1. That's why they did it. So I don't know why he has got 2 liter. Sometimes it is kind of a balance that we do. Dextrose is needed for every post-op patient who is not eating. Why? What dextrose do for us? Glucose. It's the energy. Your cell will starve, brain will starve, right? So glucose is really important for recovery. Shall we add 500 ml for insensible loss? Yes, for everyone it will be added. We added 2 liter normal saline because that was the deficit, IFAT. So we already did the math. So input was 2 liter from the IV and output was around 4 liter. So if input is 2 liter, output 4 liter, deficit is 2 liter. Okay. So that's why we added that 2 liter in that existing formula. Even if patient is diabetic, he still needs some glucose. So he can still have the dextrose. We're not going to starve the patient. And how 100 milli equivalent potassium, as I said, that for 1 liter fluid, we give 20 milli equivalent potassium. This patient, you are giving 3 plus 2, 5 liter fluid. So 5 liter, you give 100. Yeah, insulin will be given if a patient is diabetic, depends on their diabetic control and all. It's a different thing. Yes, this formula is only for patient who is not taking any oral food. If someone is taking oral food, even in the day 1 or day 2 after the surgery, for them, we don't need to give them fluid, right? It's a NG tube aspiration. It's not NG tube fluid. We don't give fluid from NG tube. We are already giving dextrose. We are not giving dextrose, Fahmida. Now, if you say why I'm not adding 2 liter in here, because 4 liter dextrose is too much for the patient. We can still give dextrose in that patient. That patient is not going to eat anything. If you give insulin in that patient and patient is starving, that patient is going to be hypoglycemic and it will just be a very devastating thing. So for diabetic patient, still we can give dextrose, especially for post-op patient who is not eating at all. Yes, so always add the deficit in the normal saline. No, it's not like that. You guys are making it difficult. It's not 20 milli equivalent for 1 liter plus 2 liter. I said in here, so 20 milli equivalent per liter of fluid. This is a different formula. If the patient was only getting 3 liter fluid, then it would be 3 into 20, 60 milli equivalent of potassium. Okay. Yeah, the deficit will be added to the normal saline. All right, so that's all in here. And Umme, you're still not getting the point. Don't know what can I do for you. This was the fluid balance sheet of the last time, like 24 hours before. This is not the one at the moment. So we're doing the fluid order for the next 24 hours. Okay? So we're not thinking about what the patient is getting right now. So the question is about next 24 hours. Post-op patient, especially like this, who is not eating, who is having a lot of drain losses, they will have a potassium deficiency. Usually we add them for every patient. All right. So that's all about today. I know it's a bit confusing. Always it happens. So you guys are not the first ones. So if still there is a confusion, maybe go through the questions again. Do the math by yourself. I'm sure you guys will get it. Okay. So now today's class is all about understanding how the questions can appear in your exam. Okay. Normally, in our question solve classes, we discuss 25 to 30 questions. Even sometimes, when you become a bit pro, we can even cover 50 questions. There are times when we can do it, but you need to be a little bit pro and know a little bit more, and we can be a bit quick. But initially, we take time. We don't overwhelm you. We make sure we go slowly but more efficiently. Okay. So don't think this is the pace of recall classes. It is not usually. So, but again, you're just starting it. I can't go too fast, then you will not understand anything. Okay. So you guys all know about our course. So I'm just going to discuss the course a little bit more, that you know that this is your first class. So even though if you are not admitted in the course, you are doing our course at the moment, because these classes are part of the course and we don't repeat this class. So it is very important, and I'm sure you know the schedules as well. So we have got multiple other free classes. So if you are not in our Facebook group, then definitely worth checking that. So if you go to our Facebook group, which is First Aid AMC MCQ, we normally update everything in here. So your next class is going to be cardiology class on 9th January, so which I guess on Friday. And then you will have two random question solved class with our other mentors. So Dr. Rabia is going to take these two sessions. One is 10th and one is 17th. So it will be similar like today. And rest of the free classes will be based on cardiology. Okay. So come and join these classes. I'm sure you're going to love it. So, and you'll learn a lot about the course, about your preparation for MCQ, which is going to be really, really important. Okay. Now, the course that we offer is the best course that you can ever find for MCQ preparation, and we can assure you that. So, and you can find out there are hundreds of students who pass from our course. We've got more than 80 students who passed in the November exam last year. So, and there are tons of students who doesn't come and say that we passed the exam, because if they say it, I'm sure it will be more than 150. So there are a lot of students who join the course, but most of the time what happens that half students do the course offline, which means they just follow the recorded videos, because I know that many of you will not be able to come to the live class, but we put the recordings usually within 24 to 48 hours after a live class. And those recorded class will stay there for 10 months. Okay. So it's a lot of time to go through the classes. Even if you miss, sometimes things happen in our life, and sometimes you might need to take a break, but the recorded sessions are going to help a lot. Okay. So don't worry if you can't join the live class. As I said, half of our students just go through the recorded sessions, and that is also more than enough for your preparation. But if you can join the live sessions, there is nothing better than that, because you get to ask questions, be more interactive, and it's really, really helpful for you. And you waste a little bit less time, because recorded class, the 2 hour class, you will take 5 hours to finish. Okay, because you will go out, you'll go for having a look at your kids, maybe go for a dinner, and you'll come back. So it just takes a lot of time. Okay. So your trial class happened, the first one we did on 6th December. You can find it in our YouTube. So this is actually our website. So if you just write firstaidamc.com.au, you get into our website, then go to the MCQ course section, and you can learn everything about the course from here. So this free 2 weeks class The Zoom ID password is going to be the same like today, just to make sure it's easy for you. The course is for 5 months. We do all the live classes. You get 3 to 4 class in a week, and sometimes more than that if needed. Class time is 8:30 to 10:30 Sydney time, and it's on the Zoom online. So we cover both theory and the questions. So we will have a complete theory based on the guidelines that you can already see. We will also discuss theory-based question. That means, let's say we do cardiology. After finishing cardio, we do a cardiology question solve. And then when you go to the student portal, you will be able to do a cardiology mock test. So this is the best way to prepare for subject by subject, topic by topic. Okay. In between the theory classes, you also go into those recall or sample question based classes. So we try our best to cover as many questions as we can. Make sure you understand the topic, make sure you understand the important things for exam. Okay. So these are our most important classes that you will have. We try to cover the recent questions in as a live class, but in the student portal, you will see all the questions solved that we have done since 2021. It will be there available for you. You also get the mock test related to the sample questions that we are going to discuss. And every month we update the questions in the portal, and you get an unlimited mock exams there. So there are lots of mock exams, subjective mock exam, monthly mock exams, and also the grand mock exam, which is like the full 150 question mock exams. Okay. So those exams are going to help you to give you that feeling of exam and how to get your timing right, because time is essence for this exam. It looks like a lot of time, but the time goes really fast if you get stuck. We cover a lot of extra things which is important for exam. You can go through this. As I said, you don't need to buy anything. All the soft copies of the books will be given to you. We still haven't got ninth edition soft copy. It's not available anywhere. Once it gets available, we will give you that. Now, we also, if you don't have enough time, because this course is going to be finished in late May. So if your exam is March, April, or May, or even in June, don't worry, because once you make the full payment for the course, you get the full access of the last batch class that we have done. So all the last batch class recording, it will be given to you as part of the course enrollment. So if you don't have enough time, you can just go through those recorded classes and finish your preparation. Okay, and that will be more than enough. All you will need to do is to make sure to do our live classes for the question solve. Okay, apart from that, everything you can cover from the last batch as well. All right, so there are lots of options in here for course enrollment. You can go through this in your own time, and I can assure you that the course is more than enough to make sure you pass your exam in the first attempt. We have thousands of candidates who passed exam from first aid AMC, and they are now a doctor in Australia. So we can assure you that there is nothing in Australia or any online platform which can give you a structured class like this. Okay. So all the researchers, so if you are already in the student portal, we have already added a lot of materials. So student portal already have materials in there. And after each class, the class materials usually get updated in the portal. So if you're asking about the question solved, usually at least the last 1 year questions should be solved. You can't download any materials from our portal. The payment option are all like online banking. So it's the credit card. So once you go into the register section in our portal, which I can show if you want. So in here, when you go into our MCQ, you'll see a register now button. So if you click on the register now, it will take you to the registration process. And the last page will ask you for your credit card. So it's like about any online payment, like how you do, it's the same. Yes, so there will be a WhatsApp group for your batch instead of the now Facebook group is always there because that's where we normally give all the schedules. But for question discussions and all, there will be a WhatsApp group for you guys as well. Okay. So books will be given. So usually we finish everything in this free 2 weeks class, and after the free 2 week session, the course students, we will provide the books into the Facebook group. So just for this initial 2 weeks, because we are already quite busy with the admission, taking the class. So once this free 2 weeks class is over, everything will be uploaded into your Facebook, okay? Especially the books and all. But you already got like the students who has enrolled already got access to the portal and materials we have already added there. And how you get access to the portal. So you go into the register now. So if you click on, so you go to our website. So if you go to firstaidamc.com.au, then this page will open and you go to the courses, 5 months MCQ course, click register now if you want to register. Once you click register now, it will take you to this. So first they will go for email verification. Then they will ask for some personal information. You will need to upload your few documents for verification purpose. Then you make the payment and then you get a confirmation. After you make the payment, it can take a couple of days for the portal access because our admin will go through all the documents and then they will approve your account. Okay. Usually, D, if your card allows online payment, then it should be accepted. So if it's not accepting, it means that that card is most likely not for online. There will be a pen and paper. Yes, in the exam, you will get a pen and paper where you can write. So the materials, so you have two options of subscription. So you can buy the subscription for 10 months, which is the standard one. And then there is a subscription for 15 months. So if someone wants to do a extended one, then you have an option of buying the 15th month as well. But most of you can usually get 10 months. Okay. All the questions will be discussed in the class, Dr. Siddhartha, so you don't need to find anything. The PDFs will be there, Selena. So all the PDFs, everything that we are showing in the class, it will be already given in the website. Now, if you guys are trying to reach us through email and messenger, I know that it's a bit waiting because we get hundreds of messages every day. And it's not just a one message, it's quite a lot of queries from you guys. So please be patient with us. Our team is working heavily. We have like 5 team members who is working for answering your questions everywhere. So, but still there is a queue. We follow the queue. We try to answer everyone, but sometimes it can be delayed a little bit. So please keep your patience, but rest assured everyone's queries will be answered. Okay. Yes, so YouTube, you will only get cardiology. It's a part of theory class, but once you enroll into the course, you will get all the other theories. E-Medici, yes, you should go through the E-Medici because the AMC is going with that. So it's not a bad idea just to read E-Medici just once. It will be fine. And Laurel, yes, previous batch recording will be enough because even the previous batch, we made sure to go in very deep research about the question. So our previous batch student is well equipped with any kind of exam. So if it's hard exam, our previous batch will be fine. So if you go with our recorded class for the last batch, it's totally okay because we followed John Murtagh ninth, we followed ETG therapeutic guidelines. So everything is there. So it will be enough. But definitely you have to come and join our live sessions for the question solve classes because that usually changes every month. Mock test can be repeated. If you enrolled today, Nusrat, it's unlikely you will get the access today because again, there are a lot of students and our admin is going through all of them one by one based on when they got admitted. So it can take a couple of days. So keep your patience, please. So what to do till 9th of January? I would suggest that the topics that we discussed today, please go through that topics and start reading them from John Murtagh. Okay? Yes, the PDFs are usually uploaded into the portal before your class anyway. So if you are asking about the CPD certificate, so CPD is not usually important for you if you are currently working in Australia in your country. So if you are a current working doctor, you don't need to buy the CPD one. So you will see a option of CPD course. That means we provide the CPD certificate. Now CPD is only needed if you have a working gap. Let's say this year or this year, yes, it's your course you are not working. Let's say you're in Australia, you're not working, or you have a gap. So if you have a gap or you're going to have a gap this year, then yes, it's a very good idea that you buy the CPD portion for the course. Okay. But otherwise, it's not needed. Yes, the portal, we will upload the PDFs tonight into the portal. So we will have a discussion, Jivan, about the portal after the free 2 weeks. Okay. Because it's a free 2 weeks, we are not going to discuss the portal right now. Portal will be discussed in your orientation class after this 2 weeks is over. But we will give you a bit of an idea about how to go through the portal in separately. There is two payment installment option for the course if you join in this free 2 week session. After free 2 week sessions, usually we usually go for like 6 weeks. After 6 weeks from today, there will be no option of installment payment. Yes, both Shrey. So if you're a teacher in a medical college in a basic subject, it will be decided as a clinical gap. You are you have a recency of practice only if you work as a doctor in a hospital or as a GP. Everything else will be a gap. So if you want to buy a book, Selena, then buy John Murtagh ninth edition. That's usually your main book. Apart from that, Kaplan Step to CK is a good book. You can buy that one as well. But John Murtagh is the main one. It's good to have a Kaplan Step to CK also, but we will provide the online version of it anyway. Reading the PDFs will be enough. So few things we discuss from the books, like when we discuss headache chapter, the full headache chapter is important from John Murtagh. So no point of bringing it to a PDF. So in that case, we normally go through the books. But most of the other topics usually will be in the PDFs So you'll be able to just go through them, and that will be enough. No, it's not okay to read eighth edition. Eighth edition is now obsolete, so you'll have to read the ninth edition. You can't print anything from our portal, you will be blocked. So just because there's a lot of scammers and a lot of trying to sell the materials, so there is no way anyone will be able to download or print anything in the course. Okay, if you try that, you will be blocked immediately from the course. And a lot of students tried that in the last batch and they got blocked. So please do not do that. I know it is sometimes difficult to read from the screen, but remember one thing, that you are preparing to become a doctor in Australia. Everything here is screen based. There is nothing paper based here. So it's better that you equip yourself with that, because when you will be a doctor here, you will look at this screen the whole time. Every patient you are going to see, you have to write it on the computer, everything. Okay. No, it requires a Wi-Fi. Dr. Iones, if you are preparing for AMC, that doesn't give you the recency. It's still clinical gap. Yes, definitely. We will guide you for all the topics that you need to read from the books. Yes, you have your option of buying the CPD letter as well if you need. All right, guys, so that's it for tonight. I hope you enjoyed our session, and there are a lot of other classes. If you have any questions, you can always ask. Okay, thanks all. It's very nice to see all of you. Start the preparation, because it's going to be a long journey, but I will try my best to make it as smooth as possible. Okay, thanks all. Have a good night.